Well, good morning. It's quite a relief we've actually got enough audience to say more audience than faculty. So thank you all very much indeed. My name is Marcus Drake. I'm a urologist in Bristol. I've got a strong clinical predominance in my work, but also in physiology. We did a lot of research when I was working in Oxford looking at spinal cord injury. And one of the things that really causes us problems clinically in spinal cord injury and lower urinary tract symptoms is the issue of fibrosis. The fact that when you have a spinal cord injury, filling the bladder becomes incredibly dangerous to kidney function. So what I'd like to discuss, quick mention of my affiliations, which don't really relate specifically to this presentation this morning. What I'd like to discuss is this very interesting observation. During a urodynamic test, what we do is we measure bladder pressure, and this is during bladder filling. Here we're doing a stress test. We're getting this person to jump around and be physically very active to try and make her have incontinence, which is the symptom she presented with. Here we're measuring bladder pressure during voiding. So you can see there's a rise in bladder pressure and there is the flow of urine. We also measure abdominal pressure during urodynamics because we need to decide whether the bladder has made an active contraction. So in red is rectal pressure, and you can see during the voiding there's actually a very slight drop in abdominal pressure from pelvic floor relaxation. So we know it's the bladder contracting, not a rise in abdominal pressure that's leading to the flow of urine. And of course we display this with our detrusor pressure, a mathematical calculation where the red is subtracted from the blue, and hence you can see that this really indicates a very effective filling property of the bladder. Because in orange is illustrated fluid being put into the bladder. So we've gone from completely empty on the left to 420 mils, and over that filling range there's been simply no change in detrusor pressure. So this is a fantastic property of the human healthy bladder, a wide range in volume with pretty much no change in pressure. So we express this as a relationship between volume and pressure, and the units accordingly are mils per centimetre of water. And you hope to see 100 mils per centimetre water detrusor pressure change. We try to measure it over the widest volume possible for accuracy, but you have to be aware that some people, you'll see that the bladder is reasonably compliant at the beginning, but then becomes less compliant at higher volumes, and we'll illustrate that shortly. So it's perhaps a little misleading to say a single value for the compliance of the bladder. So here's an illustration of exactly that. This is a man who had principally stress incontinence, though some urgency. He'd had a radical prostatectomy, and here you can see that that classic green line, well, here's filling and a pause in filling, and another fill and pause, fill, pause, and what we're seeing is related to the filling, the detrusor pressure is climbing. When you pause, it flattens out. So that means that this is not detrusor overactivity. This is a change in bladder pressure elicited by filling. And so you can see at the start the compliance is impaired, but the fuller it gets, here's a bit of incontinence, the fuller it gets, the more dramatic the pressure change elicited by filling. So here it's a steep gradient. Here, an extraordinarily steep gradient. So the real danger is arising perhaps above this volume. Now, I can't actually read the number, but I think it's about 90 mils. So in other words, this person has a real problem even at a very modest bladder capacity. So, of course, neurogenic bladder is a huge influence in our clinical practice. It's particularly with dysfunction of the sacral part of the spinal cord that we're seeing a high risk of compliance impairment to the extent that it can affect renal function. In neurogenic bladder, you can, of course, see significant thickening of the bladder wall, especially in the younger onset neurological diseases like the pediatric conditions, notably spina bifida. One of the worries that we have managing neurogenic bladder is the effect of the condition itself, but also the effect of our treatment. And catheterization is often used in treatment, and one of the biggest worries has to be a catheterized patient will have a foreign body in the bladder which will elicit a growth factor-driven reaction that can drive fibrosis, further exacerbated by the inevitable infection that accompanies catheterization. So, having already discussed that filling rate is extremely influential, let's come on to an illustration that shows, above all, how dangerous this is in the spinal cord affected individual. So this is a person who had a sacral spinal cord injury. Here you can see, even at a very slow filling rate, only 10 mils per minute, the very moment we start filling, the detrusor pressure is climbing. At this point, we've accelerated from 10 to 20 mils per minute. You could just see a very slight change in the orange line to illustrate that. And you can see how dramatic the effect is. At this point, we stopped filling. And here's the characteristic of poor compliance. When you stop filling, it either stabilizes or drops back down to where it would have been if you just stayed at the same rate of filling. And the illustration of the risk is given by this parameter. So at this point, there's been some incontinence, a leak. So this is a leak point, and the leak point pressure is what quantifies how likely kidney function will be affected. And in this case, it's 60 centimeters of water. So by rule of thumb, Ed McGuire's results suggested that any leak point greater than 40 represents a risk to renal function. And so with this individual, we are obliged to intervene because in the short to medium term, there is substantial risk to renal function. We presume that the principal risk to renal function is going to relate to the pressure within the bladder. You have no pump in the renal pelvis and only weak ureteric peristalsis to overcome vesical pressure. Therefore, you can anticipate hydronephrosis and renal dysfunction above 40. An interesting observation is the fact that a weaker bladder outlet will be protective for the kidney. In other words, the more likely this person is to be incontinent at low pressure, the worse will be their incontinence symptom, but the safer their kidneys will be. So rendering somebody more incontinent was what we used to do to manage the poorly compliant bladder. Sphincterotomy, leakage at low pressure, safer kidney. Now here we've got another neurogenic bladder. And on the face of it, everything looks fantastic. There's no particular worry because we've gone, ignoring this, which is probably an artifact, but could be detrusor overactivity. You can see we go from here to here with no net change in pressure. But actually, this is probably the very worst situation you can have, because when you take an X-ray picture, you start to understand why the pressure has not changed very much. Here's our X-ray picture, and you can see that this, if you know your anatomy of the male lower urinary tract, this tiny little thing is the bladder. Where that saline or video contrast has dispersed is not into the bladder. It's gone, of course, up into the kidneys, even distending the prostatic urethra. So the change in pressure is being soaked up not by the intended reservoir, the bladder, it's the kidneys. And therefore, you've got the very worst situation, and you will have to intervene in order to counteract this, though actually it's probably too late. So what my fellow faculty will be discussing is the physiological factors that contribute to the compliance or lack of the compliance of the lower urinary tract. And there are two aspects that are most dominant when it comes to the detrusor itself. Number one, of course, it's a large muscular organ. And so we've got an illustration on the top there of the sort of behavior that you expect from detrusor muscle. So this is a muscle strip that has been put between a fixed point and a tension measuring transducer. It's equilibrating here, but this little strip of muscle will just show a twitch, and it'll regularly show small amplitude twitches which are not sustained. And this is from a healthy human bladder. Now, the contrasting behavior that quite often you see in significant neurogenic detrusor overactivity is the powerful, sustained, fused tetanic contractions. And you can see the huge difference in amplitude of force generated by a muscle strip, which is, of course, normalized to weight, but also the fact that that's a very sustained contraction. Not at all what you want to see from a muscle that's intending to relax when filling. Now, because of this property, the muscular resistance to filling, you do quite often see a reasonable response to standard clinical interventions, which might be medications. So antimuscarinics have been used in high dose for many years to try to reduce the impact on renal function. Mirabegron seems to be promising. We've not got enough publications really to say this is a good clinical treatment yet, but it certainly seems to have a place to play. And of course, onabotulinum A has a very effective influence for some individuals at improving this adaptive relaxation of the muscle. But it's not only muscle that's influencing the compliance. And this is the key thing. You can see connective tissue infiltration. And here's an example from a spinal cord injured patient. These pictures are both from the same patient. So it's a patchy effect. But at the top you can see muscle, which is in red, connective tissue in blue. But this looks almost normal in the sense that the muscle is dominant, it looks organized, it looks healthy. But just a few millimeters away from the same patient, you can see a substantial difference. In other words, connective tissue infiltration. And your collagen in these areas is really not designed to adapt with filling by loss of tension. It's not only collagen, it's also elastin affecting these areas. So this is the same patient, two serial sections. Here we have the Masson trichome stain showing muscle, connective tissue, muscle. And elastin in the serial section, you can see this is the same muscle group as this group. And you can see that elastin is permeating the connective tissue infiltration. We have no clinical treatment to counteract connective tissue infiltration. I wish we did. When you've got a person who does not respond to an antimuscarinic or Botox, you're talking about reconstructive surgery to protect their kidneys. And reconstructive surgery, the operation itself is bad enough. It's a huge operation. But they will be spending their life subsequently suffering from recurrent urinary tract infection in many cases, the need to self-catheterize, which for a disabled population is a big problem, the difficulty that their urine is in contact with a gut segment which might reabsorb some of the key bits that they're trying to expel in their urine, plus possibly malignant transformation. So this last urodynamic slide is an illustration of the good side of cystoplasty. What we've done is cut the bladder in half. We've done it in order to relieve a very poor compliance situation. You can't, of course, leave the bladder open, so the big defect has been closed, in this case, with a segment of large intestine. So here you have a characteristic appearance of intestine stuck onto the bladder, and this is likely to be the residual part of the bladder. So you can see how effective this intervention has been for the compliance. But would we want to receive it personally in our lives? Do we really want a huge segment of intestine stuck on our bladder? Well, nobody sensible does. So what I've tried to convey is the importance of having a nice, healthy, compliant bladder. We are so lucky, those of us that have it. It's expressed as the relationship between volume and pressure. It reflects a muscular ability to adapt to filling, adaptive relaxation. The connective tissue is in modest amount in a healthy bladder, and we need it to be in modest amount because of the inability to relax by connective tissue. It's so important for renal function, and any ability to counteract the non-muscular contribution to compliance, in other words, the connective tissue influence, would be extraordinarily welcome. Over to you, Tony.